So this is that lecture. I'll be dealing with bone and soft tissue sarcomas and the like. In this lecture also I talk about metastatic bone tumors because they're much more common, especially in the elderly, and so we'll touch on that briefly, and then talk about the primary bone tumors and soft tissue sarcomas. So these are rare diseases, and the scope is very limited, and so the focus for you all is to learn to recognize, understand what's the common things and the things that can be dangerous. So my example is the garter snake in the lower left. That's pretty common. You're going to see those if you're around long enough. And coral snake is one of the things that you hope never to see, but if you do see it, you want to know that it's poisonous and be able to avoid it. So we'll talk about the treatment and the diagnosis framework for these tumors, and it's from the perspective and role of orthopedic surgeon, of course. And then there's the red on yellow will kill a fellow, and that's the little phrase. And then there's the king snake, which imitates that, but it's the red on black, so that one's not poisonous. And you learn to recognize these little things. It's very hard to diagnose something you've never heard of. That's obvious, I suppose, but in these rare diseases, it's good to have at least a little foundation, know that they're out there, and kind of be aware of what you might see. Briefly, metastatic bone tumors, way more common than primary bone tumors, and the ones we see spread to bone most often are their breast, prostate, lung, kidney, thyroid, but melanomas, any carcinoma can wind up in the bones. And they can be very destructive to the bones in case of breast and lung and kidney. Prostate cancer is more sclerotic, so bone forming. And if things are broken or about to break, we'll fix them. And radiation is very helpful for bone pain. And I won't talk too much about those right now. So our focus is on more primary bone and soft tissue tumors. I'll talk about cancerous tumors, a little bit about benign tumors and some of the ways that they present themselves. So the case example is this guy named Mark Herzlich, and I saw that he signed a new contract this year. But he was a star linebacker at Boston College as a junior. He was the ACC Defensive Player of the Year, and he goes 6'4", 240. His dad's the prototypical linebacker. His dad's a high school football coach in the suburbs of Philadelphia where I was practicing. And after the NFL drafts in April, as I'm sure you all know, right? And so at May 1st, they rate, because they don't have anything better to do when the draft is over, they rate the next year's group on like who might be the best players at a given position. He was the number 2 rated college linebacker for the 2010 draft. So he comes to my office that month with left thigh pain and swelling. I saw him on the 12th, I biopsied on the 13th, and as most of your patients will like to do, right, the day after their biopsy, they have a press conference. So that's a little intimidating considering all his results were verbally communicated based on a frozen section of some pathologist who may or may not have been a specialist. So I was a little concerned about him talking to the world about what I had told him, his parents in the patient waiting room. I was hoping that they would get that right. But fortunately, the final diagnosis turned out to be what the frozen was. So he had Ewing sarcoma in his left femur. There's another reason it's easy to talk about this is because he's been very open about it. So all these things are public knowledge. And if you watched college football during 2010 in the fall, it's kind of hard to miss all the feel-good stories that they did about this guy. He was all over the place. Looks a little different here, bald and with rosy cheeks and no face paint. So he had the classic chemotherapy. They did post-chemo radiation because that kind of kills the bone. He had a prophylactic nail to his femur. He returned to play in 2010 after skipping a year, and he had 3 interceptions his senior year. He went undrafted, signed by the Giants. His first start was in 2011. Last year was his best year statistically. And first year, not bad. He got a Super Bowl ring his first year in the league. So he did very well, and we hope that all our patients will do that well, that they'll respond to chemo, that they won't have metastatic disease, and they'll get Courage Awards and Super Bowl rings and $1 million contracts. It didn't quite all work out that way, but it's also not a diagnosis of doom and gloom either. We really have good treatments for it if we can get it in a timely fashion. Let's talk a little bit about osteosarcoma. That's the classic primary bone malignancy. See it in young people. We see secondary osteosarcomas in an older group related to radiation, Paget disease, or fibrous dysplasia. And it's usually painful, and it's a swollen area, usually right above the knee, and a destructive tumor that also can form bone. So you got to get it all out of there. We give chemotherapy before and after surgery. Here's one in the humerus with a big extra osseous soft tissue mass. You can see, and this patient also has, this is why we do MRIs of the entire bone. They have skip metastases in the marrow, which sometimes don't show up on bone scan. That's a bad prognosis associated with this. This is maybe the scariest x-ray that we'll see today. This is a kid who has a little knee pain, athlete, and the only thing you're going to see is this little periosteal elevation right there. It's called a Codman's triangle. It's a classic sign of osteosarcoma. So it needs to be studied, and you got to look closely at these x-rays. And if you step back a little bit, well, maybe a little extra bone formation in here, probably hard to see in the lighting here, but this is a subtle x-ray finding that should not be missed. In the MRI, it's much more obvious. And if you examine the patient, do a hands-on exam, you can probably feel like, oh, yeah, you're a little swollen here. There's a mass. There's something going on here. So it's something that's very detectable if you pursue that pain. And one of the themes in the other talk is really unexplained pain and unexplained masses. You just don't want to let them go. You need to have these tumors in your differential diagnosis, and you need to pursue it until you actually get the answer of why they're having those problems. Here's another example of a very large extraosseous soft tissue mass that's ossified in the classic distal femur location, and MRI showing the same thing. All right, and then we removed this guy's entire femur, and that was reconstructed with an endoprosthesis, so we do have ways of replacing the bones. Ewing sarcoma, like the one we just mentioned, very classically a large soft tissue mass and a very small amount of bone involvement. So they can be subtle on the x-ray, but if you do a hands-on exam, you're going to find these. Unlike the osteosarcoma, which is in the end of the bones, Ewing sarcoma can be in the middle of the bones. They can be diaphyseal, so a little bit different presentation. There's a classic protein on the surface of the cells and a genetic translocation that we see with these, and so it can be confirmed after the regular pathology. Like osteosarcoma, they get chemotherapy before and after surgery, and we tend to do surgery if they're removable. More often you'll see these in the axial skeleton, and so if you've got a couple of vertebrae that are involved, especially in the upper cervical spine, it's tough to do a wide resection there, and so it's something that you might just radiate. These are radiation sensitive, and it's possible to get a cure with radiation treatment. So here's one in the fibula. It's a very subtle lytic lesion, not so subtle on the MRI. We got this massive soft tissue tumor associated with this very subtle change in the bone. And under the microscope, it's a small round blue cell tumor, fairly distinctive. There's a few things in that category, and then the genetic test can confirm it. Chondrosarcoma is probably our in some ways our least favorite primary bone sarcoma because chemotherapy and radiation are not effective. It's all about the surgery, and so you can imagine if it spreads, you're in trouble because you have to actually go remove it. That's the only way to get a cure in the great majority of cases. There are benign tumors that can give rise to chondrosarcomas. It tends to be a destructive tumor, and you might get little subtle calcifications in it that are classic for a cartilage tumor. Here's another scary x-ray. This is a lady who was a dialysis nurse and was in a car accident, and in the year afterward had some shoulder pain, very subtle. You say, well, I really don't see anything there. Or MRI, she was getting treated for frozen shoulder. They finally did an MRI, marrow replacement, big extraosseous soft tissue mass blown out of the bone. So her exam, her history, the time course didn't match her injury very well, and I don't know how thorough of an exam that she got, But this is why her shoulder was stiff. It's because it was being restricted by this big soft tissue mass. So it's important to get these repeat exams. If people are not getting better in the way you thought, you need to pursue it with additional tests. And she had the proximal humerus removed and replaced with a prosthesis there. Here's another chondrosarcoma in the pelvis coming off an exostosis, very large tumor in the outer pelvis. Myeloma, it's in the mix because we see it associated with metastatic disease that's in the differential diagnosis. And it can extend down to people of younger ages as well. It tends to be painful with destructive lesions, and this is one of the few things we actually have a blood test to help us diagnose. So it comes up in that context. And so briefly, we do a serum electrophoresis. I don't tend to do urine electrophoresis anymore, but there's a protein spike there from the kappa and lambda chains that are overproduced by this tumor. Chemotherapy is important for this tumor, and autologous bone marrow transplant if you're healthy enough for that. The long-term survival is not great, but initially they respond very well. It's also very radiation sensitive. So here's somebody with a pathologic fracture, this kind of permeative destructive process that first fills up and occupies the bone marrow. And here's another similar example that was treated with cement and internal fixation. So we'll go through a couple benign bone tumors really quickly. Osteoid Osteoma is a small, painful bone tumor that's bone forming that we treat with radiofrequency ablation. And so you just will kind of see this haze of haze of bone formation. On a CAT scan, you'll see a bone formation around the outside of it and then a lytic area. They tend to be a centimeter or smaller. They produce the exact chemical that's blocked by anti-inflammatories. So they can be super painful, but people can get great pain relief with like a half an aspirin. It's really remarkable. There's another one in the femur. It's these little tiny things, and you really have to be taking the anti-inflammatory medication constantly in order to keep the pain away. Osteochondromas, we just saw an example of one of these in the pelvis. They are surface tumors of bone. They can be kind of mushroom-shaped or speed bump-shaped. And they have a little cartilage cap. And it's very rare, but they can become cancerous. Here's one down in the ankle. It's a classic spot where people might get a little bone rubbing against bone and produce symptoms. Here's one in the back of the knee. Big mushroom-shaped exostosis. So these are the bone part's benign, and the cartilage part can become cancerous, but that's unusual. Here's another one. There's the little cartilage rim right on the outside of it. You see coming off the outer table of the pelvis. So it's a surface benign tumor bone. And there's the one we already saw. Enchondroma are little islands of bone within the bone marrow. In the hands and fingers, sometimes they can cause expansion of the bone and fractures, in which case we'll go clean them out and graft them. Again, very rarely they can become cancerous, and that's associated with a lot of bone destruction, soft tissue mass outside the bone. So they have these little pattern of calcifications that sometimes called popcorn calcifications because of the arcs and rings that is a classic cartilage pattern for calcification. Very subtle to see here. You can see this in the MRI quite readily. And this one's really not doing much to the bone. It's kind of up against the bone, but it's not causing any bone thinning or destruction. And it can be seen on a bone scan because it calcifies, but that's not worrisome. That's average for all these. And I show this because there's a little tiny dent in the bone, and I don't worry about that. If it blows completely through the cortex and is escaping the bone, then that's a sign of concern. This is when a person had an enchondroma, and then they developed a chondrosarcoma right next to it. And as these get big, this will go eat up the calcifications. And so if you see calcifications that are disappearing, that's a bad sign. So this person had all these nice calcifications. It looks like someone just took there's a nice oval here, and they've just sliced right through it. So they're getting dissolved by the chondrosarcoma that formed here. And so that person had a wide resection and a proximal femoral replacement. Is doing quite well. Non-ossifying fibromas are a common bone tumor of childhood, and we'll see those quite a bit. I'll show you some examples here. Slightly expansile, sclerotic rim, classic around the knee where the growth plates are more active. We think it's a growth plate forming a fibrous tissue rather than bone for a time. They don't have a great name because eventually they do ossify and go away. It's one tumor that's self-limiting and that the body will take care of over time. All right, and very dark on the MRI. Kind of scary looking on the CAT scan. You think, oh my gosh, the cortex is blown through, but as the bone remodels and gets narrower, these tend to wind up right on the edge, and so you'll see some thinning out of that peripheral bone, but that'll eventually remodel. Solitary bone cysts are classic tumors in the proximal humerus. They're full thickness. They can cause thinning of the bone. You see a little fracture here, and they can also be self-limiting, but can really slow kids down during the ages where they want to throw a ball or be active, and the bone is subject to fracture, and they can break this over and over again. These can be a problem too because they tend to come back when you scrape them out for these kids less than 10 years old. Giant cell tumor is a common benign aggressive tumor you'll see in the distal femur and proximal humerus. You'll see this expansion of the bone, but no bone formation and reaction. And this is one that was neglected and got really big because someone thought it was a simple cyst, but they had the wrong diagnosis. And this was actually a woman who was on the police force, and they just had her staying off of it, and then just so painful she couldn't walk on it. And really, that diagnosis was not a good location for a simple cyst. That's not what they look like. She was not the right age, and it wasn't behaving that way. You know, if she was 8, maybe, but you know, as a 35-year-old, this shouldn't happen. So, yeah, no one really pursued that, and it really delayed her treatment quite a bit. But you see it replacing the marrow right down to the joint line. That's a challenging problem because if you want to clean this out and save the joint, it doesn't leave you much bone to work with. So that is a real challenge to take care of that. And we have all these giant cells under the microscope. That's what that looks like. Hemangiomas are common in the soft tissues, but they're also part of the bone. And you'll see them very commonly in the spine. You'll see these coarsened tuberculations in the vertebral bodies where you have a hemangioma. Okay, so let's talk about soft tissues a little bit. These are more common than the primary bone sarcomas. The soft tissue sarcomas are 3 or 4 times more common. So you're going to see these. You're going to see lipomas. You're going to see soft tissue masses. And it's important to have a sense of how to manage it. So we'll give you some guidelines, but there's no rules without exceptions, and the presentations of any one thing may vary a little bit. So what is soft tissue sarcoma? It's a malignancy of the mesenchymal tissues, and most of them are painless until they get big. And that's not necessarily intuitive, because you think, oh, a big tumor ought to hurt, right? Well, most of them do not until they get quite large. And so the patients often say, well, I don't want to come in, unless someone makes them come in, and they say, hey, what's that bump? On the MRI, the appearance is very nonspecific, and they can look like the benign tumors on MRI. So we'll need to get a biopsy of these when we encounter them. I often do needle biopsies in the office when I'm able. Open biopsies are even better. We get more tissue to look at. And excisional biopsies you have to be cautious of. And if something is really small, less than 3 centimeters and superficial, you could consider that. But when you take that out, the pathologist will ink the surface for margins. And you're going to have a positive margin if you just shell it out. Even so, it came out in one piece. It was really easy. It just popped right out. Well, they're going to put ink on that, and the ink's going to be on the tumor, which means there's tumor on the other side of that ink, which is still in the patient's body. And so I got to go back and take out that wound bed, and it's really hard to know exactly where to stop sometimes. If we have an MRI beforehand, that's super helpful. But I would be very cautious in doing excisional biopsies, especially below the knees and ankles where, if I have to go back and take out a big soft tissue chunk, it can be hard to close and hard to cover those areas. So it's probably better reserved for people who are comfortable treating all possibilities. There's a lot of genetic translocations with some of these tumors that help us nail down the diagnosis when there's lookalikes, and I'll spare you going through all of those, but we're understanding this more and more. Not many blood tests that are helpful, however. So the treatment for malignant soft tissue tumors, kind of like the bone tumors, is the surgery still. You got to get it all out. The chemotherapy is a little less effective, than it is for the Ewing sarcoma and osteosarcomas. It can help prevent local recurrence and metastatic disease for a time, but we're not sure if it can promise a cure in every case. We think that in some of the tumors like synovial sarcoma is perhaps a little more sensitive in some of the high-grade tumors, that it is helpful for keeping away metastatic disease and preventing it from forming. And as new agents come out, we're trying these, and we are working. It's an area of active investigation. But I think the best way to approach these is to get them early, because once they do spread, they're very difficult to treat, and it's hard to get any type of cure unless the metastatic burden is very low. 1 or 2 spots that can be taken out, and even then, new things are likely to show up. So our emphasis has been on getting them out as early as possible before they spread. All right, and as I mentioned, that the problems are lung metastases. That's where they travel to by far, and if I have to do big surgery to get it out, that's going to affect the person's function, and then also recurring on the spot, and that's why radiation is a standard treatment as well. So we'll talk about a few specific soft tissue sarcomas: the rhabdo, MFH liposarcoma, and synovial sarcoma. So the rhabdomyosarcoma is the most common one in kids. We've got about 15% in the extremities. It is the most chemotherapy sensitive. So this is a 17-year-old girl who had it in a gluteus maximus. You're seeing there, and after chemotherapy, it's really not detectable clinically anymore. It was kind of a challenge to operate on. There's a little scar from a biopsy, thank goodness, but it's hard to know how much to take out. We get a great response like that. We wish we didn't have to do surgery at all, but we're not quite at that level of being confident that we did that. We don't have that marker for a 100% response without removing some tissue and looking at it. Now, the MFH, and you heard Ruth Bachman talk about her MFH. Yeah, well, they changed the name of MFH. It used to be a catch-all term for sarcoma that really lacked the tissues of any normal, the characteristics of any normal tissue. It doesn't look like muscle, doesn't look like cartilage, doesn't look like bone, doesn't really look like anything much. And there's some in these histiocyte-looking cells. Well, that's been renamed to UPS, Undifferentiated Pleomorphic Sarcoma. And Ruth was right, it's the most common soft tissue sarcoma in adults. Here's one in the forearm with this very nonspecific MRI appearance. The treatment is radiation and surgery, and you can change the order there a little bit. Doing radiation first is nice because they can, the radiation docs will radiate the tumor and then a little cuff of tissue outside of that. If they don't have the tumor to look at, then they'll look at the wound, and they'll tend to go a little wider even than the tumor actually was. And they'll also increase the dose of radiation. Radiation works by creating free radicals, so you're not allowed to take your vitamin C and vitamin E while you're on radiation, because we want lots of free radicals in your system. That's how we injure the DNA, is we make a double-strand break in the DNA from the hydroxide free radicals that are there. So the substrate for forming those, of course, is oxygen. We want a lot of oxygen to be in those areas. So well-perfused tissues, and you expect the radiation to be effective. After surgery, the concern is that there is perfusion into all these little nooks and crannies. The blood supply is maybe disrupted mechanically from the surgical procedure. There's pockets of fluid and what have you. So we want to give more radiation to try to get the same effect. And these are some of the theories that the radiation oncologists use to justify treatment. So the great thing about doing radiation before surgery is you can do a smaller dose, and what we hope is less chronic edema. Doing radiation after surgery is nice because we have less wound healing problems. And when we radiate you before the surgery, the wounds can break down. It's particularly a problem in the thigh. So it's a give and take, and we try to individualize that treatment depending on the circumstance and the anatomic site. Anyway, undifferentiated pleomorphic sarcoma, lots of weird shaped cells in different sizes, doesn't look like anything much. So we see these huge, bizarre cells and then small pycnotic nuclei and other cells as well. Synovial sarcoma is a particularly bad one because it imitates a lot of other things. It's a challenge because it can calcify. It can have cysts in it, so it could look like a myositis or a dystrophic calcification from an injury. It could look like a ganglion cyst. And also it can sit there for years, for decades. I had a patient, and there's reports of it being present for more than 20 years. I had a patient that I think had a mass for 18 years and then it started to grow and hurt. This is one of the ones that can hurt a little bit, most of them don't. And it turned out to be a synovial sarcoma. Crazy stuff. So it has a very strange behavior and a variety of different appearances. It has a genetic translocation that helps us confirm the diagnosis. But this one can imitate a lot of different things. So there's one behind the, in the calf, right behind the knee joint, right behind the knee that's pretty heavily calcified. Here's another one. It looks like a Pancoke's tumor in the lung, but you do a CT scan, it's really all these calcifications within the paraspinous muscles, and that turned out to be a synovial sarcoma. It has, you say, well, that looks like a carcinoma. It looks like little cysts or glands, so that it has an epithelial appearance sometimes, but it's still, but it's not. This is not an adenocarcinoma, but it has that look. Here's one in the shoulder that looks like a paralabral cyst. When given contrast, you have these big areas, big voids where there's no contrast taken up. You say, oh, it's a complex cyst. So you really need to go through that carefully, and at least I do when I see these and make sure, hey, there's some solid component to this. It looks like more than a cyst. There's something that's not quite right. Here's something imitating one of those. This is this guy who ruptured a biceps tendon and had bleeding in here, and the contrast study shows a thick enhancing rim, and you think, well, that's kind of worrisome. You could follow that with an exam or another MRI or however you chose to do it. He also has a good history. You got to do a good history. I think in medical school you think, well, how important is the history in physical? I get the blood pressure. You got hypertension, you get the blood pressure medications. That's the instrument. I send you off your blood test. Your cholesterol's high. Okay. How important are all these things that I'm doing? Well, this is helpful in decision making on this guy. So did you have any problems before you pulled that door open? He says, no, I felt fine. I felt a pop and I immediately got swollen black and blue within a couple hours. Like, oh, all right, that's very suspicious. And, do you take an aspirine every day? Why, yes, I do. You find some of these people that are on warfarin or whatever that bleed a little bit more than you might think that a normal person ought to, and it all makes sense. So by the time the guy sees me, so the swelling's gone. He's not black and blue anymore. And, my biceps muscles bunched up a little bit. Classic exam, classic history for spontaneous biceps tendon rupture. All right, and so I'm worried much less about the MRI. All of a sudden, I could check it again. I could check his exam again, but it fits well for a established entity that's benign. All right, liposarcoma. There's all different flavors of liposarcomas, which we won't get into. This is probably my favorite MRI. People can have benign fatty tumors that can turn bad. And so I've had this for 3 years and now it's starting to grow. Okay, well, that could be bad. So here's a one on the top of the shoulder. See more benign fat component and then some other stuff. So this is the yin and the yang, right? The good and the evil. So this is dedifferentiated into a malignancy. It's a liposarcoma until proven otherwise. There's some lipoma variants that might have this MRI appearance, but that's a very worrisome one. And then on the T2, you see how bright that is. And immature fat cells are what you see under the microscope. So for any mass or unusual pain, you need to consider a musculoskeletal tumor. Unusual, pain that doesn't resolve in a timely fashion. That seems to be not related temporally appropriately to an injury. So it may be a pain that's at nighttime. Consider an X-ray with any of these things. That can give you some good information. MRI is really our gold standard for soft tissue masses. And if you've got persistent pain, there's no X-ray changes or subtle X-ray changes, and MRI can help you be completely sure that there's no there's no tumor there. There's nothing to worry about. Or if there is one, you'll be able to see it in great detail. That gives you the anatomy. For a bump that doesn't go away quickly, it may have come up gradually or may have just been noticed. I give the example of a professional person in my office that is a healthcare provider, and they say, well, I just noticed this mass under my arm in the shower. Let's see how big it is. It was 8 centimeters. You noticed this like 2 weeks ago, really? And how often do you shower? And so it's like, you just can't say, oh, well, that must be nothing because it just came up rapidly. You probably have an infected lymph node or something. You just never know on these things. They can come up gradually. It could have been there for a long time. You can't just throw something out because it's very old or very new. It can be reassuring if someone's had something for many years and hasn't changed, but you still have to have a differential diagnosis. And I'll come back to that in a minute. So these things can be painless. The malignancies usually are painless. Small painful things are usually benign, usually nerve tumors or other things. So MRI would really go a long way if somebody has a soft tissue mass that's sorting things out. And I would avoid treating things without a diagnosis. You say, well, that's intuitive. Nobody does that. Well, you'd be surprised. The diagnosis, a soft tissue bump doesn't count as a diagnosis, by the way. So I see people with these masses on the top of their foot. They go to see their friendly neighborhood podiatrist who tries to transilluminate it, and it doesn't really do that. It's not looking like a ganglion. Cannot aspirate any fluid. I guess it's not a ganglion, but it's bothering the patient because they're having a hard time getting their shoes on. So it's got to come out at some point anyway. So I'll just try to do that. And they kind of pick at it and they take it out piecemeal, and it winds up to be a malignancy. And they didn't get an MRI beforehand. These are really tough cases. I don't know if they got it all out. There's not a lot of soft tissue coverage there. I'm going to go remove a lot of soft tissues, a big hole in the skin all the way down to bone. That patient's going to get a free flap. That's the only way to cover that up well, if that's the type of exposure I'm getting. Whereas if you've done a needle biopsy, maybe you can spare some of the soft tissues after you've radiated it, and it's a whole different story. And so I can think of 3 patients here who've had that exact experience, and it's a big deal to go through. So the other thing too, you think differential diagnosis, well that's, we always have that, or that's just not a big deal. It's kind of like saying hello, but to the patient, you always have that. But you use it, and when things are not fitting in your differential diagnosis, is that a cue to say, oh, I need to do some more diagnostic work. I need to send this to somebody else to look at. I need to do something else here. So avoid treating patients. And by the way, if you tell the patient, well, I think it's okay, you don't have to do anything, that is a treatment recommendation. Nothing is a treatment. So if you see somebody, you don't know what it is, and you ask them to do nothing, I mean, that's an expression of how worried you are about it. So have a differential diagnosis and work through it, and you want things to fit and make sense. So, there we go. So I appreciate your attention. I'd be happy to answer any questions. Yes?
So on that last slide, there were a lot of MRI suggestions.
Yes.
When you see a patient, say in an outpatient or ER setting, who's concerned about a bump, what's the utility of ultrasound as a much cheaper modality?
Yeah, ultrasound of the if it's an actual tumor, does very little for me. It'll tell you if there's flow or not, but if it's a complex fluid collection, is it a hematoma? Is this a soft tissue sarcoma with all this cystic degeneration and necrosis? You may be able to tell something has some fatty features to it, but it's not sensitive and specific enough to tell me that there's no areas of dedifferentiation. So it's not that helpful for me. Now, if your differential diagnosis is they're on warfarin and, I don't know, the hospitals are dangerous places. You run into stuff all the time. You come home with a bruise and it's like, I don't remember hitting that. That happens to me, and I'm somewhat with it most of the time. So if it hasn't happened to you, it will. And so if someone is on Coumadin and they have this mass and they don't remember bumping it, you can't assume that they didn't. there's classic spots where you run into things, right? So outside of the hips and thighs, that's where you catch the corner of the coffee table or the drawer or whatever. So there's some locations, if you're worried, if you're differential diagnosed with hematoma, there's some locations you can be worried about it, and there's your history, and so you got to hit all those things pretty hard. Does this make sense? Does this fit with the history? But in terms of like, and that's why people come to the ER, presumably something has changed acutely. I mean, every once in a while you have someone come in with a mass and, you know, I've had this for 6 months and it just really started to hurt this weekend. I want someone to take a look at it. And, you know, if you're not going to be able to rule in or rule out soft tissue sarcoma, I mean, that's hard to do with MRI. MRI is very nonspecific. You can tell where it is, but on the MRI you can't even tell for sure what it is. So you gotta say, what question am I trying to answer with the ultrasound? Am I trying to say, this is not a pseudoaneurysm because they had a penetrating injury and it might be pulsatile, I'm having a heart. So, you know, do you want to see flow? What are you looking for? Fluid, not going to help you much. You know, a purely fatty mass that may or may not, is that going to get you out of an MRI or biopsy if it's growing and symptomatic? No way. So it's cheap, but if it's cheap and worthless, then it's a waste. So you have to really say, what clinical question am I trying to answer with this? And you have to do that for the MRI too. And you know, MRI is very powerful when people have, you know, it's swollen, it's painful. I think it's just a muscle tear. In the MRI, you showed nothing. Well, that changes your treatment a great deal. You're not having the follow-ups. You're not, you know, you go to physical therapy. You don't have to worry about you. There's you know, you can't really measure in healthcare dollars your peace of mind or the patient's from being able to say, you do not, you know, I know your leg is swollen, but it's not, there's nothing worrisome. This is a soft tissue injury that's going to be self-limited. So it's an expensive test, and I know that everyone's under the microscope for how they use these things, but also this affects your treatment plan a great deal if it's appropriate to rule out something on your, or rule in something in your differential diagnosis. So I have it, I think for my purposes, the ultrasound is usually not sensitive or specific enough to avoid another test, unless you are looking for something vascular or something that has flow in it. You know, go ahead.
By that same token, it sounds like the MRI also doesn't have great positive predictive value, because if it shows something circumscribed or maybe not so well circumscribed, you're going to have to biopsy it anyway.
Yeah, so why do you get the MRI?
To rule out other things like the muscle tear.
Right, and then the other utility of it is to say, well, but fatty tumors, lipomas I can tell on the MRI. Okay, those are pretty diagnostic. Other things I say, well, I need to, so for me, it shows the anatomy, and it is a procedure planning tool. I know where the sciatic nerve is in relationship to this mass now. I know where the vessels are. I know which muscle is involved, and so I want to go through the edge of that muscle to contain my hematoma. So I argue with the radiologist about this, and this is an area of research interest of mine, is that what can you get out of an MRI? And then that has to do too with what sequences do you do? How much, and I'll wrap up quickly because we have a couple other people that want to have some important messages for you, but you know, do you really need to use contrast in this circumstance? You really need to do 17 different sequences? What question are you trying to answer? For me, it's like, well, where is it? What's the anatomy? I don't expect you to give me a diagnosis. I just need to see where it is so I can do a safe, invasive procedure to get the diagnosis. So yeah, we hone these things down, and I'm hopeful that we can do more cost effectively. So, all right, I'll take any other questions afterward. Thank you very much.